All right, today we're going under the knife to uncover the hidden mastery behind one of the most common surgical procedures on the planet, taking out the gallbladder. Now, it might sound totally routine, but as you're about to see, there's a huge difference between just getting the job done and achieving true excellence. I mean, we're talking millions of these every single year. It's often the very first major laparoscopic surgery a training gets to learn, and the word you always hear is routine. But in surgery, routine can be the single most dangerous word there is.
So let's get right into it. If this is something happening day in and day out in hospitals all over the world, what really separates a good surgeon from a master? Well, the secret isn't just having steady hands. It's about this incredible depth of knowledge that starts way, way before the first cut is ever even made. So where does that mastery actually begin? Believe it or not, it's not in the operating room. It all starts with reading the body's own blueprint, a map that was sketched out before we were even born. You see, a truly great surgeon has to think like an embryologist. They understand that all the internal plumbing around the gallbladder is a product of our earliest development. And just like streams forging different paths down a mountain, our internal anatomy isn't always identical. Those little echoes from our formation can leave behind some really dangerous variations. And this is exactly where the textbook gets tossed out the window. The books show you this simple, clean setup. One long tube, the cystic duct, connecting to the gallbladder. But in a real person, that tube might be dangerously short, an embryonic low fusion that puts the main bile duct at risk. Or, hey, there might be two arteries where the book only shows one, or even little leftover embryonic channels. A master anticipates all of this. They know the map isn't always the territory. And to get a better look at the real territory, they use modern imaging. It's basically pre-op reconnaissance, right? An ultrasound might spot that classic double wall sign that just screams, hey, there's some serious inflammation here. An MRCP can sniff out hidden stones that would be a very nasty surprise during the operation. And a CT scan? That's the heads up that a surgeon might be about to walk into a real battlefield of severe inflammation or even a suspected cancer. Okay, so the map is drawn. Time to go in. But even this very first step, placing the surgical ports, isn't just about poking a few holes. Oh no, it is a precise, calculated move. It's what we call the geometry of safety. Every single one of those incisions is a calculation. The main camera port isn't just stuck in the belly button. It's lined up perfectly with the axis of the target. The working port goes right in the midline, a natural, bloodless plane. And the others are triangulated to create the perfect angle so the instruments work with the surgeon, not against them. Bad geometry leads to struggle, and struggle leads to mistakes. All this preparation, all this precise geometry, it all leads to one place, the danger zone. We're now entering the most critical phase of the operation, focused on one tiny patch of tissue with enormous risks. This is it, the surgical climax. Cowlett's triangle is a tiny anatomical space, but it's like a treacherous intersection on a highway. You've got this cystic duct, the cystic artery, and the main bile duct all crowded together. One wrong move in here can have absolutely life-altering consequences. And it's just filled with booby traps. A major artery can take a weird loop into the triangle, a Moynihan's hump, tricking a surgeon into cutting the liver's main blood supply. There can be tiny fragile ducts hidden in there, leading to nasty bile leaks after surgery. And if there's severe inflammation, the tissue gets so sticky and fragile that trying to dissect it is, in the words of one expert, suicidal. So how on earth do you navigate a minefield like that? Well, a master uses a non-negotiable protocol. It's called the Critical View of Safety, or CVS. And this isn't a suggestion. It's a mandatory checklist that must be completed before a single clip is placed or a single cut is made. This protocol comes down to 3 non-negotiable rules. First, clear that entire triangle of fat and scar tissue so you can actually see what's going on. Second, lift the gallbladder up off the liver bed. And third, and this is the most important one, confirm that you see only 2 structures, and only 2, going into the gallbladder. If you can't check all 3 of those boxes, you stop. Full stop. It all boils down to this mantra. Rouvier's sulcus is a reliable landmark on the liver. Stay above it, and you stay safe. And when you're in that dangerous triangle, you must remain humble. You never assume you know what you're looking at until you've proven it with the critical view of safety. But what happens when the anatomy is just too hostile, too unclear to achieve that critical view? This brings us to the highest level of mastery, having the wisdom to know when it's time to retreat. I mean, sometimes a disease like xanthogranulomatous cholecystitis or XGC turns the whole area into a block of concrete. The inflammation is so severe it creates a frozen field where the normal anatomy is completely gone. And to make things worse, it can even look just like cancer. Now, in this situation, a junior surgeon might fear that changing the plan is a sign of personal failure, so they just push ahead. A master, though, understands that true failure is causing harm. They have the wisdom to recognize when the anatomy is a trap and the courage to switch to a safer bailout procedure. A bailout procedure might mean only removing part of the gallbladder, a subtotal cholecystectomy. But as the masters say, subtotal is a friend, not a failure. The goal is always, always patient safety, not surgical ego. And that right there brings us to the final lesson. It's not a technique or tool, but a complete mental framework for approaching this so-called routine operation. This is the toolkit. Think like an embryologist when the anatomy doesn't make sense. Think like a pathologist when the tissue is frozen. Think about physiology when inflammation makes things difficult. Think like a radiologist before you even begin. And most importantly, think with humility when the body presents you with a puzzle you just can't solve. Which leaves us with one final question. In an age of incredible technology and surgical robots capable of amazing precision, what's the one essential tool that can never be replaced or automated? It's that mental framework. It's the synthesis of knowledge, of foresight, of judgment, and ultimately, the humility to prioritize a patient's safety above all else.